All right, everybody. Hey, this is Troy. Welcome back with Advanced Spine, Joint, and Wellness. And we're on at a different time. We're usually on at 2 o'clock. But hey, if you're tuning in, we have a very special guest today. This is Dr. Abbasi. You can see to my left here. And Dr. Abbasi, I'm going to let you introduce yourself, your background a little bit, and a little bit of what you're doing, because you're doing some amazing things.
Well, I'm Dr. Abbasi, and I'm what you would call a super specialized neurosurgeon who does mostly advanced keyhole, minimally invasive spine surgery, practically performing stabilization of the spine through holes that are dime size and taking the pressure off people's spine and stabilizing an unstable spine by putting in a very special way hardware, screws and rods in the spine. But you need to know that spine has a very complex anatomy. Practically, sometimes you are just a millimeter. A millimeter is 1/25th of an inch. Sometimes you're just a millimeter away from people's spinal cord. And we have to do this procedure thousands of times without putting the screws and the hardware in the wrong place. Otherwise, the consequences can be very severe. But by proper technology and training, we can do the things tens of thousands times right way and remove people's pain that are based on their spine not being in proper condition.
And you guys have multiple locations, is this right?
Correct. Actually, we have 3 locations just in Minnesota. We have multiple locations in multiple states, and we have affiliates that work with us. I go every month to another state and train a surgeon. What we do is so new that it's not taught during the residency.
How about that?
So, yeah, practically when I was learning to do this kind of surgery, when I did that, and that's not long ago, that's about just 15 years ago, when I was doing this surgery took me and my attending 7 hours. Our blood loss was 1,500 cc.
Wow.
And now I just did that surgery today in 35 minutes, and my patient go home same day. And that surgery, my blood loss usually in a surgery like that is about 50 cc, which is like
minimal.
1 cup of coffee.
Mm-hmm. So if you're listening out there, he's able to now do some of these reconstructive surgeries through almost like laparoscopically, essentially. That used to take 7 hours, tremendous blood loss. I would assume, pretty technically, difficult back then. And now you guys have got these down to 35 minutes, essentially almost outpatient with minimal blood loss. And if you've got that many locations, I'm going to assume outstanding results based on some of the research we did on you.
Well, we have been gathering these data for 10 years. And in medicine, we are, for a good reason, very conservative. We rely on lots of data. But after doing 1,500 of these cases over the last 10 years and having a tremendous amount of data, I can with very confident say that this patient does not only 10 or 20% better, they do by far in a game-changing way better than what's out there in an old-fashioned surgery.
Well, you had mentioned as well, now you're traveling the country and you're training other surgeons, so I'm assuming then training to establish new sites to be able to implement some of the procedures that you're doing?
Well, as we talked about that, this procedure is so new to a point that only few people are doing that. As a matter of fact, about 1/4 of the people who are performing this surgery are trained by me and my system. And this is kind of surgery that you cannot go to a weekend course and learn and come. And unfortunately, many of the new procedures, after we are done with our residency, we learn it going to a cadaver lab over a weekend, and then come back and do it and learn it by doing it. This is unfortunately too complex to go to a weekend course, come back and do it. So I took upon myself, and our system has, we have a campus here that we bring them in, we train them, but then I go literally get my privileges, my credentials in different state, in different hospital. I cannot tell you what a Herculean task that is. I have my licenses in 20 states and I get my privileges in their hospital. I go and help them to become good in their hospital, on their patient, in their environment, and practically we do a mini fellowship with them. I'm scheduled to go for the 4th time to Texas to train somebody, and I just came from Michigan, and I do that in many states. I think this is what's required to make the surgery and the learning curve safe. This is so different that it's like, many times doing one surgery versus another is driving a Toyota versus a Honda. Not a big difference. But this is driving versus flying. So, and we don't want ever somebody to take in the first flight and that be the last flight they have. So I go and like a flight instructor, I assure that everything goes the safest way it can go.
And the procedure, the components or the tools, I assume this is like kind of proprietary. Did you create the system with this, or is this something that you had learned yourself like abroad, or is that something that you learned here?
Well, I didn't invent this procedure, but when I saw this procedure 10 years ago and went and watched somebody else doing, first of all, I was in shock and awe. I already was, 10 years ago when I went and start looking into this, I was already an accomplished neurosurgeon. I had 23 years of training under my belt 10 years ago when I started looking into this. And when I saw this, literally my jaw dropped because I couldn't imagine that this surgery can be done this efficiently under 1 hour. A surgery that we used to do in my residence in 7 hours. I knew I can do it, but I knew it's going to take a lot of time, a lot of additional training. And I knew for other people to catch up, the procedure need to be, and for lack of other term, to be more streamlined. My blessing is that I have no other hobbies. So what I do, my work is my life, my hobby. So I put a lot of effort to make this complex process a process that anybody can do. No different than, if you remember, if you had to write a code for a web page 10, 20 years ago, you had to write the real code. Now these days, you just have to put elements together and anybody can make a web page. You have to learn it, but I made a very, very complex surgery, a surgery that any surgeon can learn.
The conditions that you're treating, I assume that you're treating a lot of conditions that some of the lay people out here that are listening to this might have heard of, like spinal stenosis, disc degeneration, etc. Those are kind of the things that you're focusing on?
Yes. And as a matter of fact, as you know, our spine is made of bone and disc. And that is many, many bones and discs from the skull to our pelvis. And this they behave and act like a tower of a car. They're pushing this bone against each other. Now, you cannot show me a tall car that's driving on the same tire for 50 years. So by the time you are 50 years, there's only 30% chance we don't have spine problem. By the time we are 60 years old, there's only 5% chance that we don't have spine problem. And by the time we are 70 years old, there's only less than 1 to 2% chance that we don't have spine problem. As you see, aging is a big factor here, and our society is getting older. People live 90s, talk to their hundreds, but our discs, they don't. And percentually, many of these patients will need some kind of spine care. We have come a long way, and we can help many of these patients without the surgery. But eventually, percentually, many of these patients are going to need spine care that includes surgical treatment. Now, the problem is these surgeries are extremely invasive, and lack of other terms, sometimes the disease, our procedure, our surgery is worse than the disease itself. how we can provide all the benefit of the surgery without all the invasiveness and the risk associated with the surgery. By literally, instead of opening you like a foot open, we can do this surgery with the dime size incision and with a tooth that is barely half an inch.
Huh. That's pretty amazing. Now, what is the procedure called? So what is this called that you're doing?
I need to give a little bit of a background regarding what we are doing. You know, our spine is in the middle of our body. To get there, we use different approaches, and all these approaches are named after anatomic kind of way we get there. The traditional way of getting to our spine is called PLIF, or posterior lumbar interbody fusion. So you know, we started doing this surgery in 1950, so 70 years ago. You would be scared and shocked to know that many surgeons are still using this approach. That is 70 years old. A little updated version of that, so we bypass the nerves in a little more favorable way, is called transforaminal lumbar interbody fusion, or TLIF. This is a procedure that came to life in 1980s. And believe it or not, still 80% of the surgeries we do is either PLIF or TLIF. So 80% of the surgeries we do are standards that are put in place in 1980s and 1950s. Already knowing this kind of surgeries, we have to not figuratively, but literally fillet open. All those muscle died. So imagine in our surgeries that we cut all this muscle and we don't reattach them in the spine. All of those muscles become scar and are physiologically dead to us. For that reason, since 1970s, we started looking for alternatives. One of those alternatives is going through your belly. We call that ALIF, or anterior, meaning from front, lumbar interbody fusion. And lumbar interbody fusion meaning getting to the lumbar spine, lower back spine, and getting rid of the bad motion there. And then we started going from lateral. We call that L, lateral interbody fusion, or L, or XLIF. Or there's a new method that we go from the front, but still through the belly. We call that OLIF, ATP, that stands for oblique lumbar interbody fusion anterior to psoas. Psoas is a muscle next to our spine. That still requires us to go through the belly. As well, in that position, that surgery, patient is on the side. If we do that, most of the time we have to turn the patient, still do a posterior fusion, meaning going from the back, putting screws, stabilizing spine. This is a tremendous amount of time spent on the anesthesia. Our surgery is called OLLIF, double L, and it stands for oblique lateral posterior lumbar interbody fusion, and a fancy name to say that you are on your belly, we make a half-inch incision on the side of your flank, and we go between the paraspinal muscle, your muscle of the spine, but actually from the back, and we go actually not into your belly, but between the belly, just in the border, thin border between the belly and spinal muscle, in that very thin plane, we go and put a dilator and reach your spine. It is like a bone God throw us to reach the spine. It is like a blessing, but it took us until 1970s, until Dr. Cambin found this anatomical approach. By the way, I talked to Dr. Cambin about 2 years ago. He just passed 1 year ago. He utilized this approach for the spine by finding this anatomic area that is void of nerves and arteries. There's a sad story here, though. He described this approach in 1970s and 1980s. And our medical community, our spine surgeon here in the United States, completely neglected that. Guess who didn't neglect that? Chinese, Korean, and Japanese. They developed a huge endoscopic approach to transcambin. Only in the last 8 years, this technology is coming back from Asia to us. So China, Korea, Japan are 20 years ahead of us. Guess another thing that they're ahead of us, and we developed but we neglected: electric cars.
Yeah.
So this like electric cars, we invented that, but we didn't really embrace it. It went to Asia, and it's now coming back from Asia to us.
How about that? That's a good roundabout on that too, because that's really interesting that that it was kind of looked at here, but then never really well established, goes abroad and then comes back. And are we seeing this now throughout the country, becoming kind of the everybody kind of looking at this in the community, going, hey, we're doing a lot of these spine surgeries daily. Like we're in the backyard of the Cleveland Clinic here, and some great hospital systems, but I can say I have not heard of this locally. And do you see this growing more within the community surgically with orthopedic and neurosurgeons?
Yeah, well, I know you're in Cleveland Clinic. Let me tell you a story about Cleveland Clinic. I just, about a year ago, I was contacted by a patient who is 500 pounds.
Yeah.
He's a very big person, and his spine had a previous surgery, and it was destabilized with the old-fashioned surgery even more, because in the old-fashioned surgery, he cut the bone. We make an unstable spine even more unstable. When he needed the fusion, a panel of surgeons in Cleveland Clinic, they told him he will die of that surgery. Truthfully, they're a good surgeon. They looked at him with his BMI. His BMI was 62.5.
Wow.
Now, BMI of a person is 23 to 27. So he was 500 pounds, and he was told he will die of that surgery. He flew to us. We did that surgery. We have a news release. You can go to OLLIF, a high BMI patient, and you see the news release about him that he came to us. He did that surgery in 2 hours. We discharged him 2 days after, and he flew home 4 days later. So being a big system does not necessarily mean that you are on top of the field. They're very good on established things, but they're not necessarily embracing new technologies. New technologies are scattered all around the US. The endoscopic is gaining traction, but as well trans-cambium approaches gaining traction. But the fusion, I can tell you that there are a few dozen surgeons in the United States doing endoscopic and trans-cambium fusions, and we have trained many of them. There are few names that are used when we do this kind of procedure. Our procedure is called OLLIF, and probably around 30 surgeons in the United States are effectively doing that. But the good news for us is, even though endoscopic discectomy, meaning just taking the pressure off, has been well developed in Asia, and they are way ahead of us, and the trans-cambium fusion, what we do, we are on top of the field, and we train actually. We had a symposium with India, with China, with Japan. We are way ahead of them in this technology. This time, my life work is going to be making sure that we in the United States embrace that. We don't neglect that. We are not going to take it back from China or Asia in 20 years. We are going to be on top of it right here in the United States.
And are you mostly focused, obviously, then on the lumbar spine? Do you have anything that you've done that's an inventive and creative and kind of on the forefront for the cervical spine then?
Well, this procedure is mostly for the lower back and the lumbar spine. There is another variation of this procedure that you are using for the thoracic spine.
Okay.
Right, spine in the chest, because the heart, lung are in your way. This is a very, very different and anatomically more complex kind of surgery. But this is a surgery that we routinely do, and to my best knowledge, we invented that regarding the lumbar spine, the olive. We didn't invent that, but we made it better. But the thoracic spine, we invented that, and we are the only people in the whole world performing this kind of surgery with a half-inch incision in the thoracic thoracic spine.
Well, and that's pretty awesome to hear, because I don't think we have anybody here locally that's even doing any surgeries in the thoracic spine. So that's pretty amazing to hear, with everything that we have locally around us. Doc, we are about out of time already. Usually 20 minutes flies by so fast. I have a million more questions. I would love to bring you back on here and hop on and do some more research on some of your patient testimonials and get into a little more specifics on things. Just in case, if someone's looking for you, what's the easiest way for a patient, or even someone in here in Northeast Ohio? We have people that watch this podcast all over the place. But what's the easiest way for someone to reach out to your clinics? What's the best contact?
Well, it is 2022. Meaning that and our patients are smarter than ever. What you need to do is just look up a minimal invasive spine surgeon and OLLIF. Just put that in. If you just put in the Google OLLIF, double L, you will see that 90% of what you find in the first 10 pages of Google is things that we have put in place. So you can go to inspiredspine.org.
Okay.
You're committed to educate our patients, our surgeons, and so on. And we don't have a clinic here. We have a campus. We have cadaver labs. We have a full lab here to train people. What I need to tell my patient, there are significant patient stories. People who have been told they need 2 years recovery, and we do a 2-hour surgery, send them home next day, and recover them in 4 weeks. This data is so available to the patient. Now, in a way, our patients are getting smarter every year by availability of the data to them.
Sure.
I started this. I could not believe what a game changer it is. For that reason, I knew if I don't believe it, I'm doing it, and it's hard for me to believe it. My colleagues wouldn't believe it. So about 2 months into doing this, when I start seeing my first patient in the clinic, I start getting patient testimonials. Meanwhile, we have way over 1,200 patient testimonials. Just if you go to YouTube and put the OLLIF in, you will see patient testimonial after patient testimonial. Over 1,000 of them we have published. Just, you have to go and listen to this patient. And they compare it. They say when their loved one, their husband, wife, friends got a surgery, what the difference was. Some of these patients has got an open surgery, and then they come and get our surgery, and they can compare it on their own body, what the difference it was getting this surgery versus another. This is truly a game changer. And our true beneficiary are our patient, and they tell their story for you on YouTube.
Well, fantastic stuff. And if you couldn't quite make that out there, inspiredspine.org, or if you just do a search for OLLIF on YouTube, Google, you're going to find some information on this amazing group. Doc, I'm going to have Julia maybe next week reach out to, who's the office manager there again? Amanda. Mm-hmm. And we will get plugged in for a second, because I have a mountain of questions for you. So thank you for your time. I know you are incredibly busy, so thank you for your time. And I'm sure all of Northeast Ohio would extend the same to you for anybody that's listening.
Well, it is truly my pleasure. As a physician, my job is not only treat patients, but as well spread the information, knowledge, awareness, and education. So I'm truly doing what I'm supposed to do. So thank you for having me.
Hey, you bet. And I can feel that passion all the way through the camera here, that this is God's purpose for you. So I love it. We look forward to meeting you again, and you guys have a safe Memorial Day weekend.
Thank you very much. You have a great day.
You too. Thank you.